Okay, well, we're right at 12:15, so we'll go ahead and get started. I wanted to first welcome everyone to our biannual virtual educational event for Rocky Mountain Cancer Centers. My name is Dr. Patrick Richard. I'm a radiation oncologist practicing at RMCC Boulder, and I'll be the moderator for the event today, talking with four of my partners about a very important topic of women's health, oncology, and hematology. So we truly hope that you'll find this a very educational event that can add to help you manage patients in your practice. I'd like to start off by introducing my colleagues today. We have Dr. Michelle Levy, who's a hematologist and medical oncologist from Denver, practicing at our Denver, Midtown, Lone Tree, and Sky Ridge clinics. We have Amy Gorsky, who's a social worker from our Pueblo clinic, Dr. Katrina Oyague, breast surgeon at our Louisville clinic, Dr. Marie Weeks, radiation oncologist practicing in Longmont and Thornton, and Dr. Jing, a medical oncologist practicing at our Aurora, Centennial, Swedish, and Littleton clinics. So before we get started, just a few basic housekeeping comments. All attendings are muted during the presentation. However, we want you to be as engaged as possible, and please use the chat feature to enter any questions or comments you have. And at the end of the presentation, I'll circle back around and give those to our attendees to answer. For those of you that carry COPIC risk insurance, your attendance is automatically reported to COPIC today so that you can earn that coveted ERS point. And again, thank you for taking time out of your busy day to join us. We worked with our panelists today to come up with topics that we hope will be of interest to you. Today, we'll be discussing iron deficiency and heavy menstrual bleeding, psychological effects when getting a new cancer diagnosis, female reproductive cancer advances as it applies to radiation treatments, after effects of female breast cancer treatment, and the psychological effects on sexuality for breast cancer survivors. Our first topic is going to go to you, Dr. Levy. I'd like you to address some of the most common signs of iron deficiency anemia.
Hi there. Iron deficiency anemia and iron deficiency can sometimes have symptoms even if the numbers aren't necessarily low. So that's something that I always like to preface this with, is that sometimes patients will be iron deficient but will not yet be anemic, and they can still have symptoms. Fatigue is probably one of the most common symptoms, which unfortunately is common in lots of other diseases that we treat. Other things like shortness of breath, palpitations are also very common presenting features of iron deficiency anemia. Some of the more unusual ones are something that we call pica, which is the craving to eat something that's not food, as well as restless legs. Restless legs, particularly at night, as well as pica. And I have seen a very broad array of pica. It's not only just sort of wanting to chew ice or dirt. I've had patients crave anything crunchy. I have one lady who eats 1 to 2 pounds of carrots a day currently because of that crunchiness. So sometimes you have to get creative in how you're asking these. I have another person with, craving sunflower seeds. So pica is not necessarily just ice or dirt. So that's an important thing to remember. And then restless legs, which again can be associated with other diseases, but is super common with iron deficiency and often corrects very quickly, is not an uncommon. It's actually probably one of the more common things that I see.
Good. So taking it a step further, if you identified a patient that you had suspicion of iron deficiency anemia, I guess what testing would you order, and then how would you manage that patient?
Sure, absolutely. So a lot of patients have started on oral iron. So I like to actually make sure that they're not taking iron the day before, or even the day before or the day of when I do their blood work, because you'll get a falsely elevated iron saturation level, and then they might not look iron deficient. And so that's an important thing to make sure. I also like to do iron labs fasting because I find that it's just more reproducible and consistent over time. So you're going to want to do a total iron binding capacity, which is going to give you the percent saturation, and then a ferritin, which is the storage iron. I always caution people that, again, not only when taking iron pills, that's going to be elevated, but also if they just had surgery, then perhaps their ferritin will be elevated. So just understanding that ferritin is an acute phase reactant and taking that into consideration is important. So that's my first step in terms of testing. Yeah.
And then in terms of management, once you've identified it, you've done your testing, how would you approach the management of iron deficiency anemia?
Yeah, absolutely. So it's also variable depending on what the patient, what their circumstances. If someone's had bariatric surgery and is unlikely to absorb oral iron, then you're going to want to skip directly to IV iron. And usually I'll do iron sucrose first. It's very well tolerated. And so I start with that. Usually somewhere around a gram is necessary for most patients who have become iron deficient. Even if they don't have signs of anemia. So any ferritin, depending on the range, maybe less than 15 or maybe less than 30, depending on the reference ranges, that will warrant IV iron. In patients who can tolerate oral iron, depending on how we think that how long it's taken them to become deficient, I sometimes don't even advise oral iron because it can be very uncomfortable. A lot of patients develop nausea, constipation, other GI side effects. Iron requires an acidic environment for absorption. A lot of patients are on proton pump inhibitors, which will decrease that absorption. And so looking at it fully, what surgeries they've had, have they tolerated oral in the past? And if I don't think they're going to tolerate oral, or if their numbers are simply too low, then it's necessary to just move forward with IV iron infusions.
Excellent, thank you. I'd like to switch gears a little bit to you, Amy. As we all know, as oncologists, one of the most critical aspects of a cancer diagnosis and how it impacts the psychosocial function of our patients, and it's something that's really important, but often underlooked. And so we know that we're blessed at RMCC to have a wonderful social work team to take care of some of those needs. And I'm curious, what are the top psychosocial needs you've encountered in a woman with a new cancer diagnosis?
Yeah, so a new diagnosis understandably brings shock, uncertainty, and certainly fear. And the combination of these can many times create that perfect storm for feeling out of control. The need for reassurance is significant during this time, in addition to providing a safe space for our patients to share their feelings and thoughts and allowing that vulnerability. I think reestablishing a sense of control with a new cancer diagnosis is critical. Equilibrium has taken such a significant hit, and being able to assist with reestablishing that sense of equilibrium is key. Creating reassurance, repeating ourselves multiple times, because as we know, when you're in a traumatic situation, you hear about 10% of what you're being told. Normalizing the abnormal feelings that will follow a new diagnosis are all ways to assist with reestablishing that sense of control.
Thank you. So I guess, what are some of the strategies which you've already alluded to, but further expand on what are some of those strategies that you've found to be helpful for women patients that have received that new diagnosis?
Yeah, sure. So there's 4 different strategies that I would suggest for those that have just been diagnosed with having a new diagnosis. The first is building a support team. It's important to surround oneself with those who lift you up and not bring you down. The energy that you have is going to need to be spent on caring for yourself. So there's not going to be time for conflict or drama or anything like that. So building that support team with individuals that show up for all the new emotions that a diagnosis can bring. The second area is becoming informed, talking to others with cancer, and to learn what helped them during this time of their lives. Find out from your medical team trusted websites that provide you with correct education and information. Possibly getting involved with a support group that can surround you with others that can identify with your current situation. And the third area is delegate, which I think so many have trouble with, but women have a difficult time with this because we're typically multitaskers. This is the time to create lists, ask others to pick up kids, run kids to activities, step back from all the extras at work that you can, and see if someone else can be a part of filling those roles for you for a while. When others ask, what can I do? Tell them. meals, errand running a vacuum, all of those things. It's important to remember when individuals ask, what can I do? They're asking because they're sincere with that and they want a task to do. And then finally, I think giving oneself just a great deal of grace, right? We aren't always so good at giving ourselves grace. This is new territory, and realizing there's going to be times when you feel vulnerable and where you feel exhausted and emotional, and just being gentle with yourself and having that grace in the situation.
Thank you, Amy. This sounds like, excellent strategies to help cope with that new cancer diagnosis. And, we've seen that the impact our social work team has on, the psychological impact of that and getting patients through ongoing treatment. So thank you. The next set of questions are for you, Dr. Weeks. The first one is, what radiation therapies are the most effective for treating specific female reproductive cancers? You're muted.
Good point. Thanks. So we've had significant advancement in radiation treatment for gynecologic malignancies. So we've gone basically from two-dimensional treatment to three-dimensional paradigms where we're able to use image guidance to help deliver doses very, very precisely using external beam treatment. Other forms of therapy used include brachytherapy, where we're able to give even higher doses right at the highest risk areas for cancer. So we use both an external beam phase, often followed by the brachytherapy.
And when you're, approaching a case like that with radiation, what would be the most common side effects that patients may experience, and how would you manage those?
Our side effects are local, so wherever we put the radiation, that's where we may expect side effects. Side effects are minimized by highly conformal treatment, but they can include anything during treatment from fatigue, stomach discomfort, nausea, vomiting, cystitis, urinary frequency or burning, diarrhea, and skin burn to the vulvar, vaginal, introital, or anal region, just depending on how low that cancer we're treating is. Long-term side effects can include chronic cystitis, urinary or bowel incontinence. These are more rare side effects, by the way, these long-term. Menstrual changes, decreased fertility is a possibility. We can weaken pelvic bones. Vaginal dryness, stenosis, and sexual dysfunction is something we counsel our patients on when we're treating these malignancies. There can even be leg or lower extremity swelling from lymphatic damage up in the pelvis. So lymphedema is a possibility. And fistula formation is another one of those rare side effects, which can be either rectovaginal or rectovesicular.
Thank you. And as a fellow radiation oncologist, I would agree that we've made quite a bit of advancement in our ability to target and accurately and precisely shape that radiation beam so that we're putting our patients at the lowest risk possible for those side effects you just went over. And also, we've also been a little bit more proactive with using things like pelvic floor physical therapy that can help mitigate some of the swelling and some of the long-term damage as well. So,
we meet with our patients every single week to follow how they're doing and mitigate as we go and get early intervention for all of those things, working closely with our gynecologist for vaginal health all the way through and that type of thing. So I agree.
Thank you. Shifting gears a little bit, going to you, Dr. Shi, would be, the after effects of breast cancer treatment. We know breast cancer is the most common cancer in women, and the treatments become very effective, but a bit complicated. So just curious, what can a woman expect in terms of some of those after effects of breast cancer treatment?
Yeah, sure. So the post-treatment effect for breast cancer treatment can be from surgery or chemotherapy or endocrine therapy. So the surgical post-treatment effects include lymphedema in the arm, chronic pain and swelling in the breast, chronic pain or discomfort for those patients who had the breast implant or cosmetic changes of the breast. So chemotherapy post-treatment effects, sometimes it can cause chronic fatigue, cognitive dysfunction, such as memory loss, and both of which can actually last even after chemotherapy is done. For premenopausal women who were treated with chemotherapy and or adjuvant endocrine therapy, sometimes it can be extended to even 10 years. So they may have early menopause, thereby suffering from postmenopausal syndromes, including hot flashes and then mood swings and so on. Endocrine therapy adjuvantly sometimes can cause long-term joint pain and vasomotor symptoms.
Thank you. And to extend that a bit more, since we know there's lots of different regimens that a breast cancer patient may benefit from, if you could speak, briefly to, the types of regimens and particularly how that impacts the long-term effects of breast cancer treatment.
Yeah, sure. So treatment for different subtypes of breast cancer can be very different. For example, treatment for HER2 positive breast cancer and a triple negative breast cancer usually involves chemotherapy. So different chemotherapy regimen may have different side effects down the road. Some chemotherapy can cause long-term neuropathy. Some chemotherapy can affect the heart, and then some do carry a very, very small risk of causing acute leukemia down the line. So the treatment for hormonal receptor positive and HER2 negative breast cancer usually involves endocrine therapy, which can cause, as we discussed, early menopause for especially premenopausal women, and then may affect their family planning as well. So with recent advances in oncology, and then we do have many new drug options for our patients in addition to the chemotherapy and endocrine therapy, including we have immunotherapy right now, we have targeted therapy for those who harbor germline BRCA1 or BRCA2 mutations. So they all carry their unique side effects as well.
No, I think that's an excellent point. And, what I'm hearing is that each individual patient should discuss this with their medical oncologist to know exactly what regimen they're getting and what those side effects may be. And, I think also just the overall health of the patient and previous medical conditions can play into that. And so it's a very individualized assessment that I know our medical oncologists are good at approaching each patient with. So thank you.
Definitely.
Last topic is going to you, Dr. Oyague. I'd like you to address some of the psychological effects on sexuality for breast cancer survivors. We know that you're one of our experienced breast cancer surgeons, and so just curious, in your experience, operating on a very sensitive part of the body, what kind of psychological effects would your patients experience as a result of that?
Yeah, thank you. So I think the take home is that essentially all patients, regardless of the surgical approach, are affected. And this isn't just from surgery, it's also, as we've already heard, from medications as well as radiation. And all of this combined means that pretty much anybody who's treated for breast cancer, and this isn't just limited to women, this is also my male breast cancer patients as well, have some sort of change to their body image, as well as change to their sexual function and experience. And so certainly the amount of surgery that somebody has can play a role. So we do try to utilize breast conservation therapy with lumpectomy where we can, as well as we try to use, minimal radiation when we can, but that's not always able to be done. And even when we spare the breast, even with lumpectomy, it still can affect the shape, the size, the sensitivity, and then the perception of that breast for that patient. Mastectomy, of course, is even more poignant because mastectomy is an amputation, and that can have both a sense of loss, you can have phantom pains, and then even when we do complicated reconstructive procedures, you have a complete loss of sensation of the skin, and particularly the nipple areolar complex, which can greatly change the sexual experience for that patient. So I think it's important, and I try to do this, and I think there's growing evidence for this in breast surgery, that we pre-cancel patients to help guide treatment decisions and set expectations to try to mitigate some of the abrupt change to that particular patient. So I do go over all of this and try to set the stage, saying even if you spare your breast, it may not function the way you want, or even if we do a nipple sparing mastectomy, you will not have the same sexual function. That said, people still go through a pretty profound change after these procedures. I also try to counsel people, and this is something that primary care providers can do too, is just remind patients to look in the mirror, touch, feel, scar massage. There's something, I don't know really how it works, but in my experience, the more that patients look in the mirror and normalize that to their own brain, it almost rewires it for that particular individual, and then they just have a better sense of, this is me and this is my new normal. And that also teaches the brain, and time does this too, but time takes a while. This is years after the procedures and treatments. 2 to 3 years is my experience after something like a mastectomy, where patients are like, okay, this feels like a part of me already. But from the standpoint of primary care providers, what you can do is just make sure that you're asking the question, because do you have issues with body changes? How do you feel in your body? And have you had a change in sexuality, sexual function? Have you had a change in your relationships? Because you're going to find that everybody has it. And for some patients, just asking the question is enough, because it normalizes it. And reassuring them that time will fix it. You won't go back to where you were before, but you'll find a new normal and it'll be acceptable. And so for a lot of people, that's enough. People that's not enough, that's where I tend to rely heavily on our social workers. They're amazing. And they have a whole slew of ways of working with people to try to come at what is the problem with the dysfunction. Because of course, sexuality and body image are very unique and individualized. And so there's not a one size fits all to treat this for a patient. There are NCCN guidelines that are available to try to start this conversation, but unfortunately they're pretty vague. And I think there is increased focus on this topic, but there aren't a lot of if this, then this. So a lot of this has to be shared decision-making, talking with your patients, and our social workers are pretty good about that, and then trying to find the underlying cause. Things to consider and to offer up to your patients are support groups. Some people really like that, other people don't, right? Sexuality and body image are pretty personal. So there's individual therapy. Sometimes relationships get affected, so couples therapy. Sometimes there is underlying depression, anxiety. That is an easy place where you can come in and treat. And then I always emphasize to patients that sometimes this is a situational thing, because patients often get upset, oh, I have this diagnosis, I'm adding another medication, I don't want another medication. But again, emphasizing this is situational, in a couple of years you may not need this anymore. Plastic surgery can get involved to fix scars and to rebuild if the cosmetics are not satisfactory. And then, I think understanding and addressing other issues that may be fueling some of the body dysmorphia issues or the sexual dysfunction. This can be, and I've seen this not infrequently, that social issues that were already affecting that patient are now more poignant given the breast cancer diagnosis. And so it might be that there are social situations that need to be addressed, living situations that need to be addressed, prior trauma such as sexual trauma, or even emotional trauma such as they watched a loved one go through a cancer diagnosis that's resurfacing. So addressing those things can actually really help people get through this time frame. And then of course, some patients just need a way to channel these emotions. So some people, that's advocacy, they go out and advocate for breast cancer treatment. Other patients that might be focusing on themselves, like Amy was talking about self-care with respect to physical activity, lifestyle modifications, and that's a good way that we can channel what they need to do for their own cancer risk reduction and improved survivorship, and also, help treat some of these underlying issues with my body doesn't look right, or it's not functioning as needed. I think I probably addressed both questions in one.
very comprehensive answer to those important questions. And I mean, I think it's fascinating your comment on, encouraging a patient to look in the mirror and to, to feel the area and really just see what it looks like, because I can't tell you how many times, I've seen a patient after a lumpectomy or a mastectomy and say, well, how are you healed? And, they basically say, I don't know, you tell me. I don't even want to look at the area. So I think there's, I've never have heard it described as you did, but it's pretty enlightening that, a lot of our patients just don't even want to look, much less feel the area. And that creates more of a barrier to addressing those important issues. So, the most important thing, as you suggested, was create awareness, talk about it, ask people. And before we get on to some of our questions, I'd like to tie you in, Amy, and also, just curious from a social worker point of view, how because obviously you guys create such a safe place for our patients to express these emotions. How often are breast cancer patients or just women patients in general bringing up sexuality with you?
It's a more common conversation than you would expect. I think that especially when, many times in that conversation, the social worker can also weave that into the conversation. And once we open that conversation and that topic, I think they realize that it's not anything to be ashamed of or be inhibited with. And so, again, I think when we are also talking about that as social workers, as physicians, they feel safe to have that discussion as well.
Yeah, that makes sense. And I would be remiss not to put in a shameless plug for a support group program we have for any patients up in the Boulder area at Boulder Community Hospital. RMCC has partnered to create to bring in a sex therapist to have a several part seminar that's going to be after the new year, where it's just that patients come together, and it's just for female patients to come together and have that discussion. And it's all about openness. And one of our sex therapists is great at dealing with a lot of those issues. So we do have a couple questions from the attendees. The first would probably be best for you, Dr. Levy. What are your thoughts on slow iron? This particular provider has found less side effects with it. So curious your thoughts on that.
Yeah, I think it can be super effective. I would say that, it's interesting when you think about the mechanism of iron absorption and sort of the regulation with hepcidin. I definitely recommend against doing multiple times a day iron. Yes, it can up your numbers at the beginning, but what it does is it actually downregulates hepcidin, which is the protein that allows iron to actually get stored. And so I do prefer using once daily dosing for patients who are going to do oral iron. I found that there are some supplements such as like Blood Builder or Hemaplex that also have iron, as well as B12, folic acid, and vitamin C, which is effective for the absorption. So those are some supplements that I also recommend, although I have nothing against slow epi. I usually pick some of the other ones in favor of that. The Blood Builder particularly doesn't have a ton of iron, but is well absorbed. Hemaplex has actually 85 rather than 65 of iron. So that's a really nice supplement as well. And so I tend to favor those. But again, if you've had patients who have minimal side effects, then absolutely go for it.
So I'm going to ask maybe the silly question of what, and then you've alluded to this, but what are you referring to as slow iron? Is that just kind of a low dosing that's multiple times a day, or can you just give the basis for what slow iron is?
Yeah, it's honestly just like listed as slow epi. It's supposed to have a sort of more extended release type mechanism. But yeah, okay. Literally it's like, it just says slow epi. That's usually how it is over the counter. I see someone just asked a question about the products that I mentioned. Yeah, both of them are over the counter. Blood Builder has a lot less iron. That's a supplement that I often have patients go on. Let's say you've got patients with heavy menstrual bleeding. They come in, their ferritin's like 5. They absolutely need IV iron at that point. Once I get their iron stores up, At that point, something to maintain them throughout their heavy periods is usually sufficient to be oral at that point. And so blood builder, which I usually just tell my patients to get on Amazon, same thing with Hemaplex, HEMA-PLEX, another supplement that has a lot more in it. But these are good supplements that tend to, I have found with my patients, maintain women and men, depending on the reason. If they don't have an absorption issue, they can maintain very nicely and limit the number of IV irons that are necessary at the time of follow-up.
Excellent, thank you. I have a question for you, Dr. Shi. As we, discussed, the type of regimen, can impact the long-term effects from treatment. And I know this is a big question and partially putting you on the spot, but with anti-estrogen, I think that's, the one that's on the forefront of a lot of our breast cancer patients' minds. Just, without going into a lot of the details, what is your general approach if a patient comes in and says, Dr. Shi, I'm kind of leaning towards not doing this treatment, or how would you help guide that discussion?
Yeah, sure. We actually do encounter this a lot. And then some of them are just having side effects from endocrine therapy. And then I do want to point out that for the primary care physician that we do have several options for endocrine therapy, tamoxifen and aromatase inhibitor. And then under the category of aromatase inhibitor, we have 3 sister drugs. Efficacy-wise, they are pretty comparable to each other, but side effects, it just happens to be, one drug work better than the other for one particular patient. And then so sometimes we do switch things around and then to see which medication works the best for that particular patient. And also we do have sometimes to like a dose reduction, like a tamoxifen does come with like 20 milligram dosage. So we can do like a half of a dose. So some of the patients, they are just like over anxious when they were told that they need to be on this medication for 5 years at least. And then they Googled everything and then was super anxious to start. And then sometimes I'll just, ease them in and start them with 10 milligram. And then if they tolerate well, and then we can, escalate to the full dose. Or, some patients we can, do like a aromatase inhibitor, anastrozole is a 1 milligram dose. And then we usually do not do dose reduction because it's 1 milligram. So we can do like, sometimes I do once, every other day instead of every day. And then just to, try to find the best, dosing regimen for the patient to ease them into the full dose. And also, sometimes I do find that this phenomenon in terms of the mechanism of action, I'm not quite sure, is that some patients, they are on this and then having some joint pain or other issues. And then we do something called a drug holiday for just 2 weeks. And then 2 weeks, we stop the medication. And then 2 weeks later, we restart the medication. Surprisingly, some of my patients actually, after this brief discontinuation of the medication and the resumption of the medication actually, resolved the vast majority of the side effects they have had before. I'm not quite sure about the mechanism, but it actually worked several times for several of my patients. So those are usually the clinical strategies that we use to, to help them maintain on this, essential medical treatment to help with prevent the breast cancer recurrence. And
excellent, thank you. Oh,
sure. And in terms of side effects management, I just want to briefly go over this. There can be a lot of side effects from endocrine therapy. Some patients may have some GI issues. Some patients may have some mood swings, and hot flashes is very common. Joint pain is very common. So we do have different ways of tackling those side effects, including, drug treatment or, exercising, and then a lot of approaches.
thank you. And we'll stick with you with the next question. We have an attendee that is a healthcare provider and also was a patient. And, she makes the comment that one of the worst treatment medications was Zometa infusions. And just curious if you can address, the common short-term and long-term impacts of Zometa and how you may, approach somebody struggling with that.
Yeah, so Somata is the bone strengthening agent that we use for if the patient has metastatic breast cancer with bone metastases, and then we usually use this to prevent, to help prevent the fracture. And in the adjuvant setting, it can help postmenopausal women who has a breast cancer if they also has like osteopenia, osteoporosis, and then it can also decrease it's a small benefit, 3% of the benefit to decrease the risk of bone metastases, like a bone recurrence in the adjuvant setting. So usually for the Somata infusion, it can cause flu-like acute phase, and it can cause flu-like symptoms for some of the patients, like a headache and some just feeling tired or muscle pain, things like that. And then long-term wise, it does have a risk of 2% of a risk of causing osteonecrosis of the jaw. So usually before we start this medication, we always get the dental clearance to have us to be able to prescribe this medication, making sure that the patient does not need any invasive dental procedure in the near future. And then Somata, there's a very similar agent that we use for the same purpose. Is called Xgeva. So Xgeva, they serve the same purpose. It's just one is the small infusion and the other is the injection. They kind of carry the same side effects. Xgeva can cause the osteonecrosis of the jaw as well, and both of them can actually cause, can have effect on the calcium metabolism as well. So yeah, I mean, dental surveillance and then dental clearance is very important for those for both agents. And then Xgeva is special in a way that it can cause something called a typical fracture. This is something in the long run that we need to look out for our patients as well. Sometimes if this happens, and then we need to discontinue this medication indefinitely. Yeah, these are the side effects that we usually encounter the most clinically for our breast cancer patients.
Thank you, Dr. Shi.
Mm-hmm.
Amy, I have a question for you. We talked about how important social worker are for the initial diagnosis, new cancer diagnosis, but a lot of the issues we've discussed today may not impact that patient till they're months, years after treatment. So I'm curious, kind of what is your approach in the survivorship setting, with some of these long-term issues?
Yeah, I have seen that sometimes it's at the survivorship appointment that we actually start seeing a lot of the psychosocial piece, right? Because when you're initially diagnosed, so many times you're just focused on getting through it, right? Creating that plan and honoring what it is that you're needing to do medically. So by the time survivorship comes, all of these emotions that, are a part of realizing, wow, I have been through a lot, come out. And so again, being able to normalize those feelings, because I think it's a lot like grief and loss. When you are going through grief and loss, it seems like there's this time frame stamped on your forehead of when you can grieve and when grief is done. And so it's very similar with a cancer diagnosis. Is the losses that accrue during this, you sometimes don't even realize it until the survivorship piece. And so it's, again, being able to talk with someone who has the ability to be of support and be present to you during that time of vulnerability, and trying to normalize an abnormal time.
And if I can add to that,
sure,
real quickly, I think these things are really important to address, especially in the survivorship venue, because they affect future care decisions of that patient. And if you don't address some of the trauma that's associated with the diagnosis or the experience of that patient, then they're more reluctant to do, sorry, the lights went off in my room. They're more reluctant to do other treatments down the road. So they may not do their surveillance. They may not, if they have a recurrence, they're going to be more reluctant to therapy. So finding these things, addressing them, asking the questions, normalizing it makes a huge difference to how people do in the future. So it's extremely important.
Totally. And to, piggyback off of that, I mean, I have started the practice of basically acknowledging with each one of my patients that what we've done is medical trauma. Now, of course, beneficial in terms of treatment, but all of this experience for so many of our patients is traumatic. And just like you said, Dr. Oyague, acknowledging that, creating a dialogue around it, and, if needed, referral to social work for the survivorship period is very important. And we did do a presentation on survivorship. This was, a few months ago. So hopefully that's archived somewhere where we presented on the survivorship issues, and it definitely extends what we're talking about here. We have a few minutes. I'd like to stick with you, Dr. Oyague. I'm just curious, in your discussions with patients that are really struggling with that, lumpectomy versus mastectomy decision, in your experience, what would have the more impact on sexuality in terms of a lumpectomy versus a mastectomy?
I think that's really complicated. And it has to do with that particular patient, because for some people, their breasts are really important to their sexuality, achieving orgasm, all of that. Other people, their breasts are not. And so you have to actually ask that question, which we do. And then other people, it really is their partner or their appearance. And so the cosmetics become a bigger issue than actual sexual function. And so I really do think it's a lot of conversation, and you have to ask the question, meaning that's what I meant by pre-counseling, is setting people up for the expectation. Your breast may look amazing if we do a nipple sparing mastectomy with implants or autologous reconstruction, but they're not going to function. But if all you really care about is how well you look in a swimsuit, and that's what your body image and your sexuality is based on, then it doesn't matter. But if saving your breast because that function is really important, then a bilateral mastectomy would be catastrophic for that individual. And so trying to save the breast as much as we can make a big difference for that individual. And so it's really teasing that out. And then again, I think setting that stage, having those conversations in the beginning make a huge difference to how people recover, because they're like, oh, I knew what I was getting into, right? But if you don't preemptively say this is what's going to happen, they can't. And then a lot of people are like, well, I thought it was going to be worse than this, because when you painted that picture, I was like, oh gosh, and this is less than what I expected. So then that also helps, right? So I think just having big open conversations, and it's individualized. And I think the treatment afterwards is talk to your patients and ask the question. People want to hear it, and it's normal, right? It's when they've run studies on this. There's a recent one at a University of Colorado, actually, where they surveyed patients, and it's like 93% of patients will have at least one symptom with respect to sexual function or body image. So and that's not just breast cancer, it's all cancers, right? All of the female cancers, colon cancer. I haven't met a cancer patient that doesn't have something affected with their body or their relationships from their diagnoses. So we just have to talk about this stuff, just like we do depression screening, we should probably do sexual health screening.
Totally. No, I again, that creates that openness and dialogue that a lot of our patients would benefit from. So, we're almost at the top of the hour here. So I just wanted to thank all of our panelists for taking time out of their day to join us. And also in the chat window in Zoom, we did post that you can check out that survivorship previous session on our website. So please go there if any aspects of survivorship are of interest to you. Want to thank all of our attendings today. Hopefully you got a sense of how we would approach some of the issues regarding women's health and hematology and oncology. We certainly welcome any feedback you may have to make these events more meaningful in the future. And again, we hope you have a great rest of your day and a happy holidays and good start to 2023. Thank you.
Thanks.
Thank you.
Thank you.